Minutes Matter by Chance J. Rogers. I wrote a literature synthesis that reviews the efficacy of TXA administration in the pre-hospital trauma setting, and if we're actually improving patient outcomes by administering this medication. Some studies show no clear improvement in 6-month survival, while other studies support and encourage its use in the pre-hospital trauma setting. This is a literature review briefing for Minutes Matter, the case for pre-hospital tranexamic acid in trauma patients with suspected hemorrhage. Gone are the days of just being ambulance drivers. Since the start of the modern ambulance in 1967 with the Freedom House Ambulance Service, pre-hospital emergency medicine has undergone a paradigm shift from being a simple transport unit to now establishing care, treating prophylactically in the field, recognizing life, health, and limb hazards, and participating in cohort studies to improve the future of medicine. Paramedics respond to a multitude of emergencies divided into two widely accepted categories: medical and trauma. Pre-hospital providers have a plethora of treatment modalities for both categories: physical application of a device, pharmaceuticals to include narcotics and vasoactive medications, and electrical therapy. The medications carried on an ambulance constantly change. The change can be in a given dose, indication, contraindication, or added or removed based on if the medication is shown to be safe or effective. Some medications are even removed or replaced due to political reasons. According to the National Library of Medicine, the anti-fibrinolytic effects of TXA are due to the reversible interactions at multiple binding sites within plasminogen. The binding of TXA to the lysine receptor found on plasminogen prevents plasmin from binding to the receptor, ultimately stabilizing the fibrin matrix. In essence, TXA does not form clots. Its action is to prevent clots from being destroyed in a process called fibrinolysis. TXA only has FDA approval for heavy menstrual bleeding and to prevent bleeding during dental procedures. TXA is not FDA approved for its use in the trauma setting. Therefore, administration in this context is considered off-label. The lack of FDA approval in the trauma setting can raise suspicion to its effectiveness. Why are we using a drug that isn't FDA approved for the reasons we give it? The lack of FDA approval does not indicate that a medication is not effective in certain conditions. Epinephrine is a medication commonly used to treat anaphylaxis, asthma exacerbation, and is also used to treat non-perfusing arrhythmias and cardiac arrest. Some of the above listed uses of epinephrine are considered off-label, as the FDA has not approved it for such use. The only FDA-approved uses for epinephrine are in cases of anaphylaxis and to improve hypotension associated with septic shock. This alludes to the idea that FDA approval is seemingly worthless in the pre-hospital environment. If a drug we use in every cardiac arrest isn't approved for that setting, then why should we consider what the FDA has to say at all? This is reinforced by the fact that use of TXA in trauma settings is supported by the National Association of EMS Physicians, the American College of Surgeons Committee on Trauma, and the American College of Emergency Physicians, all of whom are key opinion leaders. A trauma compendium conducted in 2016 revealed support for TXA administration in the field for suspected hemorrhage after life-saving interventions had been performed. The study recommends a slow intravenous or intraosseous push of 1 to 2 grams within 3 hours of onset of injury. It also cites that administration after 3 hours can increase patient mortality. A controlled trial named CRASH 2 was published in 2013 that studied the effects of TXA administered to trauma patients and aimed to determine if administration within a certain time frame increased the total amount of life years gained. A life year gained is a metric in health economics that measures the additional number of years a person is expected to live because of receiving a specific treatment without measuring their health-related quality of life. CRASH 2 concluded that TXA can increase life years gained when given within 3 hours of onset of injury and is most effective when given within 1 hour. In 2023, the New England Journal of Medicine released the results of a trial that studied 1,310 patients to determine if pre-hospital administration of TXA yielded a greater number of patients with a higher quality of life after injury compared to a placebo group. Quality of life was determined based on the Glasgow Outcome Scale Extended. The GOSE has 8 levels, where level 1 is death, and level 8 is no injury-related problems. Favorable functional outcome in this study was defined as a GOSE of at least 5 or higher. Level 5 is defined as lower to moderate disability. At the end of the 6-month survey, the group that received TXA only had 0.2% higher favorable functional outcome when compared to the group that received a placebo. According to the study by the NEJM, our administration of TXA improves survival rates, but does not significantly change a patient's quality of life compared to if they would have survived their injuries without TXA. The CRASH 3 trial, released in 2020, observed a relationship between patients who received TXA that had a severe isolated head injury and an increased mortality rate. Patients who only had a traumatic brain injury and were given TXA had a 4.49% increase in mortality when compared to patients who only had a traumatic brain injury and did not receive TXA. It is important that local protocols have isolated head injury listed as a contraindication. TXA has been slowly integrated into the EMS formulary over the last 15 years, and I believe it is here to stay. Majority of evidence shows an increased positive outcome in patients who receive it. It is important to use TXA prudently when a head injury is suspected. Its safety and efficacy have been proven by multiple extensive trials, solidifying the support for its use in the pre-hospital care environment.